Good morning, and thank you very much indeed for giving me such a warm welcome. It's a privilege, if you can hear me well. It's a privilege to be here, and the topic, when it was presented to me, seemed simple enough, but as I prepared for this talk, I realized how difficult actually the topic really is, primarily because of lack of information specifically regarding the question that we wanted to address, which is ovarian responsiveness and oocyte quality. With respect to ovarian responsiveness, it's not that much of a problem, but with respect to the oocyte quality, there definitely is inferences rather than direct data. I have no disclosures. So, okay. The screen is very different. It's bright green. So this slide gives you an idea of all the things that can potentially go wrong with respect to endometrioma, even if it is not taken care of or operated upon. So if you look at these three items, increased requirement of GnRH as well as the associated cause and possible side effects, the risk of cycle cancellation, and challenging oocyte retrieval are potential problems. But in addition to that, during retrieval, you can have follicular fluid contamination as well as infection of the endometrium subsequently, although rare, can be having a devastating consequence to the patient. This particular graph was taken from Hamdan et al.'s paper. It's an excellent review, and I pretty much am going to concentrate this talk on the results presented in this particular publication. But before I get to that, there are three papers that have not been addressed in this particular presentation that I would like to highlight. Well, first one is by Maggiore and co-workers. Looks at endometrioma and its effect on ovarian reserve. So, if you accept antral follicle count as the prime marker of oocyte or ovarian responsiveness, you can see that consistently the ovaries that are healthy have more antral follicle counts than the ovaries that have endometriomas. But if you accept AMH as a better arbiter of ovarian responsiveness, then let me magnify that for you. It's a little bit less clear depending upon which study you want to look at. So the first study, which has the most, it's hard to use this pointer, I apologize, as the most number, indicates that AMH concentration in patients with endometrium is actually better than the ones in the controls. But if you look at the rest of the studies, the AMH, as one would expect, has less value than the ones in the control patients. The next paper that is very interesting but looks at a different set of values, and this is sort of contradictory to the summary by Hamdan et al., is by Rustan. What they did was categorized or looked at patients who suffered decreased ovarian reserve after removal of the endometrioma and compared them with patients who have idiopathic DOR. So the first thing that is striking is age. Patients who had decreased ovarian reserves subsequent to surgery, endometrioma surgery, on average were younger than patients who had idiopathic decreased ovarian reserve, at least in their study group. And more interestingly, when they compared patients as a group, 125 cycles, it's not patients, 125 cycles in patients who had decreased ovarian reserve after endometrioma surgery with patients who had idiopathic DOR, 243 cycles. As expected, the cycle cancellation rate was actually higher in patients who had endometrioma surgery. And the duration of stimulation as well as the total dose of gonadotropin used was also higher in the patients who had endometrioma surgery. However, the number of mature oocytes obtained were similar in both groups, although the fertilization, surprisingly, was higher in the patients who had endometrioma compared to patients who had decreased ovarian reserve. And the number of embryos obtained was also significantly higher in patients who had endometrioma as opposed to idiopathic DOR. So the some inferences, although they have decreased ovarian reserve based on this response, they actually had better oocyte quality, presumably, because the fertilization rate was better, as well as the number of embryos obtained were also higher. But then they went ahead and further applied the Bologna criteria to subcategorize the patients in the endometrioma group as well as in the decreased ovarian reserve group, just to level the playing field, so to speak. And in this case, cycle cancellation rate was again higher in the patients who had endometrioma. The duration of stimulation as well as the total dose of gonadotropin used was also higher. However, when you look at the fertilization rate, it was still the same in that patients who had endometrioma had better fertilization rate, although there was no significant difference between the number of embryos obtained. So here's the kicker. So one would expect then that the live birth rate should be higher in patients with endometrioma as opposed to the patients with the decreased ovarian reserve. But surprisingly, the live birth rate was actually lower, significantly lower in patients who had endometrioma as opposed to patients who had idiopathic DOR, which was carried through when they subcategorized the patients with the Bologna criteria as well. So it's a little perplexing, but the way I would like to explain this is that oocyte quality is one thing and embryo is one thing, but then ultimately implantation is another thing as well. And in patients with endometriosis, there are multiple factors that could be going on. However, oocyte quality itself may not per se be affected. But that's one study. Now I would like to, before I move on to Hamdan et al.'s very extensive review of the literature and meta-analysis, I'd like to present this one paper to you, where they performed endometrial ablation or ovarian cystectomy, just as a sidebar, and showed that size matters in that if the ovarian endometrioma is more than 5 centimeters, you are more likely to have decreased AMH value with cystectomy as opposed to plasma jet ablation. It's a surgical vignette, and I thought I'll throw that at you because I saw a poster yesterday where they're talking something similar about injecting vasopressin prior to dissection to decrease the effect on the ovarian reserve. Anyway, coming back to the question under discussion, whether ovarian reserve or oocyte quality are affected by endometrioma, the impact of endometrioma on the IVF-XC outcomes by Hamdan et al. Is an excellent source to look into that. I'm not putting this up on the screen so that you can read it, just to show you how many papers they actually reviewed. And of these, the one that is highlighted had no treatment given. So almost all papers looked at that look at endometrioma and the effect on IVF-XC always seem to look at surgical intervention followed by the effect on IVF and XC, unfortunately. So it's very hard to dissect that out and see what happens if you don't operate on endometrioma at all, though there is some evidence in these as well. So they had total of 33 papers that they thought was worth including in the meta-analysis. I would more describe it as a systematic review because the vast majority of these papers, in fact all of these papers, were retrospective in design, and of the 33 studies, only 3 had no intervention compared to the rest of the studies that had surgical treatment. And more importantly, the vast majority of the studies had very low numbers. There are a couple of studies that recruited patients in the hundreds, but the vast majority had subjects of less than 50. So that is an inherent limitation to conducting a meta-analysis. So the first categorization that they made was intact endometrioma versus no endometriosis. So the number of oocytes retrieved was significantly lower in patients who had endometrioma, and better if they had no endometrioma. However, the GNRH used based on all these papers was not significantly different, which is different from the one that I presented earlier from Rustan, in that showed that they required higher gonadotropin dose as well as longer duration of stimulation. Here the FSH dose in the meta-analysis was not significantly different. However, cycle cancellation rate was higher, again showing that endometriosis does decrease your ovarian responsiveness, and whether you end up using more FSH or not and stimulate longer or not, cycle cancellation itself is significantly higher in this group of patients. How about patients who have endometrioma and no endometriosis whatsoever? These are patients who had tubal factor, male factor that they compared with. Again, surprisingly, the live birth rate was no different between intact endometrioma that is not treated versus no endometriosis. And if you compare endometrioma versus endometriosis, that is patients who have peritoneal endometriosis with patients who have, in addition, endometrioma as well, the live birth rate, the cycle cancellation rate, as well as the oocytes retrieved were not significantly different. So essentially, once you have endometriosis, whether you have endometrioma per se, didn't seem to make a huge difference. And even if you treat the endometrioma and compare it to patients who were untreated endometrioma, the live birth rate and the cancellation rates were all similar, which I would summarize to say whether you have endometriosis per se is probably the most important question. Once you have endometriosis, whether you have endometrioma and whether you treat it or not treat it doesn't seem to actually make a huge difference with respect to your ovarian reserve or your ability to have a live birth. Again, as I mentioned earlier at the very beginning, studies looking at oocyte quality per se are obviously lacking, and we have to make inferences. And my inference is that there is decreased ovarian responsiveness, generally speaking, in patients once they have a diagnosis of endometriosis, regardless of whether they have endometrioma or not. And oocyte quality is probably unaffected, as live birth rate doesn't seem to be affected in these patients. Thank you.